So I haven't included the Cardiff patients in the review, but this is just a review from across the UK of 67 cases. And you can see that, as you would expect, the majority of them did already have existing pressure ulcers, but certainly a common theme across this is patients with multiple pressure ulcers, and primarily that's about being able to position the patient. So one of the things we generally say to people is, if your patient's got a pressure ulcer, try not to reposition them on the pressure ulcer. If they've got multiple pressure ulcers, that becomes very difficult. There isn't a body surface you can turn them to keep them off the pressure ulcer. 4 of these patients had major trauma. Only 2 of those were the military ones. The other 2 were road traffic accidents. So I think if we talk very much about military trauma, it excludes a lot of people, but certainly other people see either industrial or road traffic accidents. And one of the groups that I know we've found difficult to place have been the bilateral amputees. Particularly if you're using alternating therapy, because of the reduced leg length, what you see is that those patients really don't like that system. If the cells underneath their bottoms deflate too much, the limbs come up, they feel very unstable, they find it difficult to get in and out of the bed. So we had 6 patients with bilateral amputation. We also had in there 8 patients with kind of perineal, perianal, genital wounds. Some of those were pressure ulcers, so thinking through the kind of pressure ulcers I know I've dealt with, often the guys with gross heart failure, where they get a lot of edema in that central region and they get their very swollen testicles, very difficult to manage. It's not an easy thing to elevate. They get the very big legs. Just getting in there is difficult, maintaining the patient dignity while you do that. And once they start to get a reduction in that, what you find is there's often significant damage underneath. And I'll show you an example of that. And we also had 4 patients who were septic. So a lot of these patients tend to be in the more intensive areas, so high dependency intensive care. This is not an everyday therapy that we're talking about. So looking at the primary reason for use, you can see pressure ulcer management obviously is going to be the most common one. However, for many other patients, almost half the patients, what we're talking about is pain management. And with most of the equipment, you can reduce the handling of the patients, but we still need to reposition patients for other reasons. And looking through these groups of patients, there are a whole host of reasons why manually handling them, turning them would increase pain. So there were patients with severe arterial disease, so severe claudication, but there were also terminally ill patients where even the slightest movements caused them additional pain. 6 were palliative, and in many ways you might say, well, you don't need additional support for palliative patients, but one of the things that some of the staff talked about was the ability to not disturb the patient and the family. So it's a much softer outcome. So yes, you are preventing the pressure ulcers, but what you're also doing is at that end of life stage, giving the family and the patient a little bit more dignity, a little bit more quality time together, and I think that's a really important outcome to manage. Reduced turning frequency was the actual reason for use in 17 cases, and I think that reflects a whole host of things, whether that's the pain or the dignity, or for some people it's just about the complexity of turning patients who may have abnormal positions, abnormal conditions, multiple wounds. There were 4 patients that the only reason cited was that they were just very complex, and 4 where they were non-concordant with turns. And again, the non-concordance could relate to pain, or it could be confusion, or it could be certainly things like stroke patients. They don't like being put on their one good side, so they will automatically turn back. And actually for 6 patients they talked about microclimate management, so patients developing moisture lesions or certainly sweat damage, and being able to reduce that using the same piece of equipment that was preventing the pressure ulcers. So very positive outcomes for all the patients, and most of the patients had some or all of these. But I think for me the one that was most significant that cropped up in most of the evaluation was around patient comfort. And if you're able to keep your patient comfortable, then that has knock-on benefits for them. So when patients are comfortable, they are more likely to sleep, they're more likely to eat, they're more likely to become caught up with their care. And you'll see from one of the quotes how benefit that is on the families. Many of the patients in the trial already had existing pressure ulcers, as I said, some of them multiple ones, and they all reported that there was no additional damage, and certainly some achieved considerable healing or improvement during that time, with one patient actually being discharged 2 weeks earlier because of the significant improvement in their wound. They were able to go home and be managed in the community. They all had their moisture damage improved, and I mentioned this thing about the multiple pressure ulcers where you don't know how to position the patients. All of those patients, the staff cited that they felt confident to lie the patient directly on those pressure ulcers, and what they saw was it's still an improvement in the wound condition. So no new damage occurred, they all had reduced turning times, and certainly for those patients who were palliative, there was an increase in end-of-life comfort. So whilst there were many quotes, I've only chosen two, and I chose these two for really specific reasons. This patient on the left that talks about providing patient comfort and ease the family anxiety. This was a 4-year-old child, and I know for most people dealing with children is very emotive, but any of you who've got children will know that for a family, having your child being incredibly sick is a very, very stressful experience, and it can make the interaction between healthcare staff and the patient and their family very difficult, purely because of tension. But knowing that the family feel much more relaxed and much more at ease actually makes those interactions better, and knowing that their child was comfortable was significantly important to those patients. And you can see from the second quote here from a lady with obviously a much older patient, a husband, saying how much she felt much more at ease, how much she felt relaxed just because she knew her husband appeared to be comfortable and she could have much better interaction with him, and that she could tell without asking that he was in far less pain just from his attitude. And certainly what we saw with some of these patients was their overall condition improved. As they were more comfortable, they started to take more fluid, they started to eat more, and obviously that has benefits for their wound healing process. So in terms of thinking about how you fit this into the product mix that you already have, we wouldn't suggest this is an everyday thing. We're not recommending it for large groups of patients. It's got to be a very considered approach, thinking about their risk status and existing damage. We're very much encouraging people to use their clinical judgments. If the patient has got existing damage but a Waterlow score of 7, then ignore the score, because if the patient's got a pressure ulcer, they're at risk, or else they wouldn't have. And I think for some people that still remains a challenge, and certainly from the presentations we've had, we know that. One of the issues we've faced is the difficulty stepping the patients down. Once they are comfortable on a piece of equipment, they really don't want to come off it. And clearly, Sarah, you've experienced that with your patients. Getting them to move down to a less sophisticated piece of equipment is not always the easiest thing in the world. So this is just one example of a patient that we used Dolphin for, a complex patient in many ways. Came in because of self-neglect and kind of gave up once he was in very, very quickly. Came in not really mobile, but able to be transferred and weight bear a little bit, and within 4 or 5 days was in bed and virtually contracted. So you can see he's got multiple pressure ulcers which deteriorated very, very rapidly, and he did develop some new damage. This was at a point where he dropped his blood pressure, his HB was 6.4, he missed 1 2-hourly turn and developed 3 new pressure ulcers. Just because he was so poorly, and the reason he wasn't turned was they discovered all these other things and there was a lot of medical interaction and intervention going on. But certainly this new damage across his foot occurred during that time period. But if you look at where he's got them, so you can see here, these are the kind of ones I was talking to you about, where underneath the testicles and behind the testicles as well, you've got an awful lot of not necessarily big pressure ulcers, but managing those, putting dressings on those is not the easiest thing in the world, both down the lateral margin of the foot, both hips. And how on earth do you position this patient so they're not under pressure ulcers? It's very, very difficult, in considerable pain, and so he was moved on to the Dolphin with particularly good results. And again, once he was more comfortable, actually started to engage a little bit more with the staff and started to get a little bit better. So how we work through where we're going to use Dolphin is we kind of have this list of criteria that would be our framework that we work from. So if the patient's got multiple or extensive pressure ulcers, that would certainly be worth thinking about. Pain related to either repositioning or to the pressure ulcers or the perianal wounds is definitely a different one. We've had a couple of patients that were in the study who had genital tumours, so fungating tumours. There's one lady with a vulval tumour, and they are incredibly distressing for those patients. They tend to be quite malodorous. The ladies tend to be older, and they find it very undignified managing those wounds. And they're often very painful, and not sitting on them is not an easy thing to do. Difficulties in turning can be about the trauma, so when they've got multiple trauma, getting hold of them and being able to turn them is a problem. medication, so if they're on high doses of inotropes, if they're on some of the cardiac drugs, you can send them into cardiac arrest by repositioning them, and that's not something that would be your choice to do. So where possible, you try and reduce the frequency of turning or reduce the degree of turn. Sometimes just a small turn helps. Obviously spinal instability, you don't want to be doing any significant movement. And we saw the one patient who got spasticity, but we've had quite a few patients with things like spinal deformity who are very difficult to place on things like alternating systems, and it also reduces the amount of the mattress that they spread across, so they're within a very small area. So particularly some of the systems that have got pressure mats in particular parts of the mattress, they don't fit into the right areas of the mattress. You get the heels up next to the bottom, so they not get the heel protection, the heel bit, because the heels aren't there. And just generally, if the patient has incredibly complex needs, whether that's medical needs or practical needs, then that would be another criteria to consider it. So we would consider the Dolphin for any individual one of those, but particularly if the patient has more than one, then that might be somewhere that we think about using the Dolphin in practice. So you can see it's not an everyday solution, but certainly where you do need it, it is a very useful solution. Thank you.